Parkinson's disease. Etiology. Parkinson's disease is an idiopathic degenerative central nervous system disorder. This means that the symptoms of the disease are due to the progressive loss of neurons in the brain. It is the most common cause of Parkinsonism, a syndrome manifested by rest tremor, rigidity, bradykinesia, and postural instability. Symptoms are mainly due to neuronal loss that occurs specifically in the substantia nigra. Don't confuse Parkinson's disease with Parkinsonism. Parkinsonism refers to clinical syndromes that mimic the symptoms of Parkinson's disease. For example, tremor, bradykinesia, rigidity, and postural instability due to secondary causes like drugs, metabolic, and neurodegenerative diseases. Prevalence. It is the second most common neurodegenerative disorder following Alzheimer's disease. Age of onset. 60 years in sporadic cases because genetic factors are thought to play a major role, especially in cases of disease onset before 50 years. Parkinson's disease is also associated with loss of dopaminergic neurons in the substantia nigra pars compacta, resulting in major disruptions in the connections to the thalamus and motor cortex, leading to decreased dopamine, increased acetylcholine, and decreased serotonin. This leads to Parkinsonian signs such as bradykinesia. Mutations in the gene encoding the lysosomal enzyme glucocerebrosidase GBA gene on chromosome 1. GBA is the same gene which is deficient in patients with Gaucher disease, which increases risk of developing Parkinson's disease. Parkinson's disease can sometimes be confused with progressive supranuclear palsy. Progressive supranuclear palsy usually presents as an isolated vertical gaze palsy, followed by paresis of other ocular movements and signs and symptoms of Parkinsonism, that is tremor, bradykinesia, rigidity, and postural instability. Pathophysiology. Dopamine is released from the substantia nigra pars compacta to act on the striatum. Dopamine activates the D1 excitatory pathway, thus promoting movement, through the following steps. D1 neurons directly inhibit the internal segment of the globus pallidus. Inhibition of the internal globus causes decreased release of gamma-aminobutyric acid to the thalamus. Decreased release of gamma-aminobutyric acid to the thalamus leads to disinhibition and promotion of movement. The indirect pathway is tonically active and acts to suppress the movement. Dopamine inhibits the indirect pathway by binding to D2 receptors, thus promoting movement through the following steps. Inhibition of D2 neurons causes activation of the external segment of the globus pallidus, which projects gamma-aminobutyric acid to the subthalamic nucleus. The subthalamic nucleus is inhibited and releases less glutamate to the internal segment of the globus pallidus, less activation. Less activated internal globus decreases the release of gamma-aminobutyric acid to the thalamus, leading to disinhibition and promotion of movement. In Parkinson's disease, stepwise dysregulation begins when the D1 neurons are not activated by dopamine. Lack of D1 stimulation means that these neurons will not release gamma-aminobutyric acid to the internal segment of the globus pallidus. The internal globus will now be disinhibited and release gamma-aminobutyric acid to the thalamus. Acting on the thalamus, gamma-aminobutyric acid will inhibit movement. In Parkinson's disease, stepwise dysregulation begins when the D2 neurons are not inhibited by dopamine. Disinhibition of D2 neurons mean that these neurons release excess gamma-aminobutyric acid to the external segment of the globus pallidus. The globus pallidus, now inhibited, releases very little gamma-aminobutyric acid to the subthalamic nucleus. The subthalamic nucleus is now disinhibited and releases excess glutamate to the internal segment of the globus pallidus. The internal globus, now overstimulated, releases excess gamma-aminobutyric acid to the thalamus. Acting on the thalamus, gamma-aminobutyric acid will inhibit movement. Parkinson's disease classically presents with mnemonic, trapped, pill rolling, tremor causing illegible handwriting, cogwheel rigidity, akinesia, postural instability, stooped simian posture with shuffling, festinating gait, expressionless, mask-like face, dementia, late manifestation. Other processes that can cause Parkinsonian-like signs and symptoms include post-encephalitic Parkinsonism, trauma, drugs and toxins. Post-encephalitic Parkinsonism has a viral etiology. The most characterized epidemic is thought to be related to the influenza virus. Trauma is a prominent cause, especially in professional fighters with brain injury secondary to repetitive brain trauma sustained over years. For example, Muhammad Ali developed Parkinson's disease after years of taking punches to the head. Agents commonly implicated in drug-induced Parkinsonism include high potency, typical antipsychotics, for example, fluphenazine, haloperidol. Antiemetics, for example, metoclopramide. Vesicular monoamine transporter inhibitors, for example, reserpine. 1-methyl-4-phenyl tetrahydropyridine, a contaminant in the street drug 1-methyl-4-phenyl 4-propionoxypiperidine. 1-methyl-4-phenyl tetrahydropyridine is oxidized to 1-methyl-4-phenylpyridinium, which is taken up by dopaminergic neurons within the substantia nigra. This metabolite subsequently induces mitochondrial dysfunction, leading to neurodegeneration. Note: although the majority of cases of Parkinson's disease appear to be sporadic, there are genetic forms of Parkinsonism, designated Park1 through Park13, related to nuclear and mitochondrial genes. Novel genetic forms of Parkinsonism are likely to emerge from future research, thereby shrinking the large majority of Parkinson's disease cases currently regarded as sporadic. Pathology. Depigmentation, neuronal loss, and gliosis, particularly in the substantia nigra pars compacta and in the pontine locus ceruleus, are typical abnormalities found in the brains of patients with Parkinson's disease. The normal substantia nigra is characterized grossly by a thick, dark streak in the midbrain, separating the cerebral peduncles from the rest of the brainstem. In Parkinson's disease, destruction of the neurons in the substantia nigra leads to depigmentation of this region. Microscopically, neurons of the substantia nigra reveal Lewy bodies, which constitute the pathologic hallmark of Parkinson's disease. Lewy bodies are round, eosinophilic, intracytoplasmic neuronal inclusions of alpha-synuclein. Neuronal degeneration is also present in the dorsal nucleus of the vagus and the medulla and other brainstem nuclei. Note: immunohistochemical studies have demonstrated that Lewy bodies are made up mainly of alpha-synuclein and ubiquitin and also contain calbindin, complement proteins, microfilament subunits, tubulin, microtubule-associated protein 1 and 2, and a Parkin substrate protein called PALE-R. Pathogenesis of cell degeneration. Irrespective of the initial trigger, etiology, of the neuronal degeneration in Parkinson's disease, the pathogenesis of neurodegeneration probably involves either programmed cell death, apoptosis, or necrosis. Apoptosis is characterized by condensation of cytoplasm and chromatin, deoxyribonucleic acid fragmentation, and cell fragmentation into apoptotic bodies, followed by lysosome-mediated phagocytosis. The other mechanism of cell death, called autophagy, is characterized by the accumulation of autophagic vesicles, autophagosomes, and autophagolysosomes, and also plays an important role in neurodegeneration in Parkinson's disease. Clinical manifestations. The cardinal features of Parkinson's disease are tremor, bradykinesia, and rigidity. A fourth feature, postural instability, is commonly mentioned, although it does not generally occur until much later in the course of the disease, and is thus Not included in any published diagnostic criteria for Parkinson's disease. Tremor. The tremor in Parkinson's disease, typically described as pill rolling, is a rest tremor, meaning that it's most notable when the tremulous body part is supported by gravity and not engaged in purposeful activities. Tremors in other conditions, such as essential tremor or multiple sclerosis, are typically action tremors, in which the tremor occurs when the affected limb is being used. Bradykinesia. Bradykinesia is a generalized slowness of movement and is present at the onset of Parkinson's disease in approximately 80% of patients. It is arguably the major cause of disability in Parkinson's disease and is eventually seen in almost all patients. While it is the most common feature of Parkinson's disease, it is also the most difficult symptom for patients to describe. Weakness, incoordination, and tiredness are often used to describe the decreased ability to initiate voluntary movement. Rigidity. Rigidity is increased resistance to passive movement about a joint and occurs in approximately 75 to 90% of patients with Parkinson's disease. Rigidity, like tremor and bradykinesia, often begins unilaterally and is typically on the same side as the tremor if one is present. Rigidity eventually progresses to the contralateral side and remains asymmetric throughout the disease. Cogwheel rigidity can be seen in Parkinson's disease, and the term refers to a ratchety pattern of resistance and relaxation as the examiner moves the limb through its full range of motion. This phenomenon is thought to be a manifestation of tremor superimposed on increased tone. However, not all patients with Parkinson's disease have cogwheel rigidity. Many instead will have lead pipe rigidity, a tonic resistance that is smooth throughout the entire range of passive movement. Rigidity can affect any part of the body and may contribute to complaints of stiffness and pain. Postural instability. Postural instability is an impairment of centrally mediated postural reflexes that causes a feeling of imbalance and a tendency to fall with a significant risk of injury. Because postural instability usually does not appear until later in the course of Parkinson's disease, patients with Parkinsonian signs who fall early in the course of the illness most likely have another Parkinsonian syndrome, such as progressive supranuclear palsy or multiple system atrophy. Postural instability is tested clinically with a pull test, where the examiner stands behind the patient and firmly pulls the patient by the shoulders. Patients with normal postural reflexes should be able to maintain balance and retropulse, step backward with no more than one step. Patients with Parkinson's disease and postural instability, on the other hand, are likely to fall or take multiple steps backwards. Among the primary motor features of Parkinson's disease, postural instability is the least responsive to dopaminergic therapies. Other motor features. In addition to the cardinal manifestations, other motor features of Parkinson's disease include craniofacial, for example, mass facial expression, hypophonia, visual, for example, hypometric saccades, eyelid opening apraxia, musculoskeletal, for example, micrographia, stoop posture, and gait, for example, shuffling, short step gait, freezing, abnormalities. Non-motor features. Parkinson's disease is a complex disorder with diverse clinical features that include non-motor manifestations. Cognitive dysfunction is most common problem with executive function, decision-making or multitasking, memory retrieval, and visuospatial misperception. Psychosis is most common with visual hallucinations. Sleep disturbances include frequent awakenings, restless leg syndrome, rapid eye movement, and sleep behavior disorder. Excessive daytime sleepiness and fatigue. Mood disorders, including depression, anxiety, and apathy or abulia. Depression is the most common psychiatric disturbance seen in Parkinson's disease. Apathy has been defined as a primary loss of motivation, characterized by diminished speech, motor activity, and emotional expression. This definition of apathy is essentially synonymous with that of abulia, which has been defined as a loss of the impulse, will, or motivation to think, speak, and act. Diminished motivation is the key concept in both apathy and abulia. The neurologic basis of apathy and abulia is most commonly ascribed to the frontal lobe and limbic system dysfunction. Pain and sensory disturbances. The pain can be lancinating, burning, or tingling, and can be generalized or localized to different areas of the body, including the face, abdomen, genitals, and joints. Painful sensations in Parkinson's disease tend to correlate with motor fluctuations. Dystonia, which is often painful, is a common symptom in Parkinson's disease. It can occur spontaneously in early Parkinson's disease, or it can occur when levodopa wears off. Autonomic dysfunction, including orthostasis, constipation, dysphagia, diaphoresis, urinary dysfunction, and sexual dysfunction. Orthostatic hypotension is very common in patients with Parkinson's disease, even relatively early in the course of the disease. Common urinary symptoms indicative of autonomic dysfunction in patients with Parkinson's disease include frequency, urgency, and urge incontinence. Olfactory dysfunction. Olfactory dysfunction is very common in Parkinson's disease and can manifest as deficits in odor identification, discrimination, and detection. Dermatologic findings, most commonly seborrheic dermatitis. Other dermatologic changes include hyperhidrosis and dermatophytosis. Diagnosis. The diagnosis of Parkinson's disease during life is based upon its distinctive clinical features discerned from the history and neurologic examination. At a minimum, bradykinesia plus either tremor or rigidity must be present in order to consider the diagnosis of Parkinson's disease. Diagnostic criteria. Bradykinesia plus tremor or rigidity. At a minimum, bradykinesia plus either tremor or rigidity must be present. Response to dopaminergic therapy. An unequivocal, beneficial response to dopaminergic therapy is an important supportive feature of the diagnosis, while the absence of an observable response essentially rules out the diagnosis of Parkinson's disease. Other supportive features. Additional supportive features are a marked improvement with dopaminergic dose increases or marked worsening with dose decreases, unequivocal and marked on-off fluctuations, the presence of levodopa-induced dyskinesia, rest tremor of a limb, and the presence of either olfactory loss or cardiac sympathetic denervation on meta-iodobenzoguanidine, iobinguan 1,2,3 scintigraphy. Red flags and exclusions. Red flags are potential signs of alternate pathology, though with a low or uncertain specificity. These features argue against the diagnosis of Parkinson's disease. The determination that Parkinson's disease is a cause of motor Parkinsonism requires the presence of supportive criteria to counterbalance the presence of any red flags and requires the absence of absolute exclusion criteria. Drugs to treat Parkinson's disease. One of the first-line strategies for Parkinson's disease is to increase dopamine availability in the central nervous system, especially in patients older than 65 years. To remember the drugs used, better remember the mnemonic Balza, bromocriptine, amantadine, levodopa and carbidopa, selegiline, antimuscarinics. Bromocriptine. Bromocriptine is a dopamine receptor agonist, ergo alkaloid. Note: newer, non-ergo dopamine receptor agonists, such as pramipexole and ropinirole, are now preferred for the treatment of Parkinson's disease over bromocriptine, which is associated with a less favorable side effect profile. Ergo dopamine agonists, for example, bromocriptine, have mostly been replaced by non-ergo agonists because of significant side effects, for example, pulmonary fibrosis. Amantadine. Amantadine was first used to treat influenza, but in the central nervous system, it has the interesting effect on both increasing dopamine release from presynaptic terminals and also inhibiting its reuptake. It also antagonizes N-methyl D-aspartate receptors, preventing glutamate signaling in the basal ganglia. Patients who take amantadine can expect to have less bradykinesia, tremor, and rigidity. The main indication for amantadine, however, is that it helps reduce dyskinesias due to levodopa. A side effect for amantadine is livedo reticularis, purplish discoloration of the skin and a lace-like pattern. Levodopa and carbidopa. Levodopa is the most effective treatment for motor symptoms and initial treatment in Parkinson's disease. Levodopa is the main drug used to increase dopamine in the central nervous system. While dopamine cannot cross the blood-brain barrier, levodopa can. Levodopa is converted into dopamine by dopa decarboxylase, which is present both in the central nervous system and in the periphery. Because dopa decarboxylase is present in the periphery, levodopa is given with carbidopa, which inhibits peripheral dopa decarboxylase. This allows more levodopa to cross the blood-brain barrier, where it is then converted to dopamine in the striatum. This is also useful because it decreases the adverse effects associated with increases in peripheral dopamine, namely severe nausea and vomiting. Common acute adverse effects of levodopa include nausea, vomiting, orthostatic hypotension, arrhythmias, hallucinations, confusion, especially in elderly patients. Long-term use of levodopa-carbidopa can result in dyskinesia after administration and akinesia between doses. Monoamine oxidase B inhibitors, selegiline and rosigoline, and catechol-O methyltransferase inhibitors, entacapone and tolcapone. Selegiline, monoamine oxidase inhibitors, plus catechol-O methyltransferase inhibitor, for example, entacapone or tolcapone, leads to decreased dopamine breakdown. Entacapone is a peripheral catechol-O methyltransferase inhibitor, while tolcapone is a central and peripheral catechol-O methyltransferase inhibitor. Antimuscarinics. Antimuscarinics like benztropine can also be used to treat Parkinson's disease, leading to decreased tremor and rigidity. Management of non-motor symptoms in Parkinson's disease. Antidepressant medication. In most patients with Parkinson's disease who desire drug therapy for depression, serotonin norepinephrine reuptake inhibitor or a selective serotonin reuptake inhibitor rather than a tricyclic antidepressant is recommended. When prescribing antidepressants to patients with Parkinson's disease, you should be aware of QT interval prolongation, drug-drug interactions, worsening motor symptoms, exacerbation of restless leg syndrome, and rapid eye movement sleep behavior disorder. Anti-anxiety medication. Pharmacologic options for anxiety include selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, and buspirone, similar to the general population. Psychosis. Psychosis, mainly visual hallucinations and delusions, is a frequent complication of Parkinson's disease, especially in patients with cognitive dysfunction. Preferred antipsychotic drugs are pimavanserin, quetiapine, or clozapine. Second-generation antipsychotics are less likely to exacerbate Parkinsonism than first-generation antipsychotics. Clozapine may be the most effective antipsychotic of the three, but requires hematologic monitoring. Chronic use of antipsychotic drugs has been associated with increased all-cause mortality and cardiovascular events in older patients with dementia, as well as in patients with Parkinson's disease. First-generation antipsychotics, risperidone and olanzapine, should be avoided because they have a well-established high risk of worsening motor symptoms in patients with Parkinson's disease. Excessive daytime sleepiness. Management of excessive daytime sleepiness in Parkinson's disease involves efforts to improve nocturnal sleep hygiene and to treat causes of poor nocturnal sleep. Pharmacologic treatment with modafinil, methylphenidate, or judicious use of caffeine during the day may offer some benefit. Autonomic dysfunction. For detrusor hyperactivity, consider medications without significant central nervous system effects when available. For example, trospium chloride. For neurogenic orthostatic hypotension, consider droxidopa. For constipation, encourage lifestyle and dietary changes for constipation. Consider polyethylene glycol or probiotic therapy. For erectile dysfunction, consider sildenafil. Sialorrhea can be treated with botulinum toxin injections, glycopyrrolate, or sublingual atropine. That's all for the video. We'll see you next time.